So I hope that you will enjoy this meeting. And to start in beauty, we will start with the first keynote speaker, who is Dr. Victor Zhou. So Dr. Dzau, who is a very renowned scientist in the field of cardiovascular medicine and genetics, he did the pioneering seminal work on the renin-angiotensin system, is a graduate from McGill University. He did his MD degree at McGill, where he probably met his wife, who is a Montrealer, so there is a special bond between Dr. Dzau and us in Montreal. Dr. Dzau is currently the president of the National Academy of Medicine, formerly the Institute of Medicine. In addition, he serves as chair of the Health and Medicine Division Committee of the National Academies of Sciences, Engineering, and Medicine. He is Chancellor Emeritus and James Duke Professor of Medicine at Duke University, and the past president and CEO of the Duke University Health System. Previously, Dr. Dzau was the Hersey Professor of Theory and Practice of Medicine and Chairman of Medicine at Harvard Medical School's Brigham and Women's Hospital, as well as Chairman of the Department of Medicine at Stanford University. He will speak today about opportunities and challenges in the implementation of precision medicine. Please welcome Professor Dzau with us.
Thank you, Joanne and Daniel, and of course a special thank you to Pavel Hammett, whom I've known for too many years to tell, maybe 30 or longer, and it's a great pleasure for me to be here. It's a great pleasure for a whole number of reasons. First of all, this is such an important topic, personalized healthcare to precision medicine, and secondly, of course, as you heard, I have my roots in Montreal and also in Canada, and of course when Canada calls, I always say yes. Okay, so I thank the organizer asking me to talk about this topic. In my capacity as the president of the National Academy of Medicine, we think a lot about this, and I'll tell you some of the work that we're doing in this arena. So maybe first, of course, is that a little definition. Many of you know this meeting is about personalized healthcare, which is fairly broad. And of course, one important aspect of it is precision medicine. One could also argue, of course, this is also personalized medicine, so I don't want to spend a lot of time arguing about the definition, but more so demonstrating the opportunity that's afforded by us now with such advancement in patient engagement, data, and of course technology that can truly move us now to a very different era altogether. Now this definition we took from actually President Obama's, the Council of Advisors of Science and Technology, or PCAST, which was written in 2008, and the co-chairs were Eric Lander and John Holdren. The National Academy's National Research Council in 2011 took this further and modified the definition and wrote a very important report, which I'll tell you briefly about. And here is defined as the tailoring of medical treatment to individual characteristics of each patient, to classify individuals into subpopulation that differ in their susceptibility to a particular disease or the response to specific treatment, allowing preventative therapeutic interventions to be concentrated on those who benefit, sparing expensive side effect for those who will not. I think you all would agree the fundamental principles of what's articulated here. This is what we all want to do, aspiring as clinicians, providers, and researchers. Now, the NRC report, which is part of the National Academy, actually this 2011 report went a little bit beyond just defining precision medicine, but pointed out that we need a new taxonomy of disease. That is that with the huge amount of new data network that emerge, that can integrate research and, of course, molecular makeup disease and individual patient characteristics, we're now in a very different era. The era calls for new taxonomy whereby, in fact, diseases are defined by their underlying molecular basis and potentially other factors related to it. This report, in fact, in many ways have coined the term, I won't say it's the only one, but coined the term precision medicine. Now, I think the question for many of us is, of course, the promise of personalized healthcare and precision medicine. I think we all recognize that if it's really met its own, realized its full entire promise, it would have effective treatment, effective prevention for a given individual patient, and therefore overall improve individual and hopefully population quality of care while reducing the need for unnecessary diagnostic tests and therapies. And as I said, when you apply at the population level, it should actually, as I'll talk about later on, improve public health, because there's always this argument between individual precision medicine versus public health. I think they actually converge. And so particularly if you think about using the technology as a way to define risk prevention and risk assessment and prevention. Now, we all know that in 1961, when the Framingham study published what we call now risk factors, they were really mainly predictive factors, weren't they? So in a way, we have already began the journey some years ago when all my physician colleagues says we always have practiced individualized therapy, because for this individual patient, we look at what that patient needs and we make that decision. And of course, Framingham added additional factors for you to decide when and what to treat and when and what to intervene. I think the difference today, of course, is the great advancement in technology and information, which will make things even more precise. So from prediction to precision medicine, I think that's where, in fact, we're thinking about. Now, as you can see in this slide, there are examples of which precision medicine has already been used. These are really specifically genetic diseases or very specific cancers, as you can see, where the genetic abnormality is identified, where you can target the therapy. And so that, in fact, is already in play. So what's new about today, in my opinion, is the advances. When you think about the fact that now you have not only the whole genome, human genome sequence, but also all the related technology in the measurements of metabolomics, proteomics, peptidomics, etc., there's also the important factor that these technologies are getting easier, more available, and more affordable. Of course, most of us think about the $1,000 genome sequencing as the signature of where the inflection point is. That is that the price will go low and low, faster and faster, and with that technology, why not make it available to every single individual? And hence, won't that be a huge amount of information? Now, in addition to that, as you know, with mHealth, digital health, sensors, and all those ability to collect information, the huge amount of information collected and analyzed will allow us now finally to put many pieces, not only genomics, but other factors, environment and others, into the equation, whereby the individual patient can actually look at the characteristics. And now a clinician can say, I can actually predict, but maybe precisely predict, or close to precision, identifying risk, prevent disease, improve diagnosis, improve effective therapy, and maybe reduce cost. That is the promise, and it is the right time. Why? Because we are at the point where the breakthroughs already occurred, technology is available. So I think for all this excitement in this room, I think it's a chance to bring all these pieces together for our patients, clinicians, researchers, and others. So in that context, the question is the path to precision medicine. Well, when the Human Genome Project is now, how many years old? Pavel, how many years ago? Yeah, 15 years. I remember Francis Collins wrote the paper to say within 10 years we'll be able to do all those things. Well, not yet. And I know that what really the meeting here is not so much about the technology, is how to find a pathway from not where we are today all the way to truly realizing precision health. So the national academies, we used to be called Institute of Medicine, and we have always been devoted to asking this question in terms of where are scientific advances, medicine going. And we have a roundtable that's ongoing for about 7 years on genomic and precision health. And what's unique about the roundtable at the National Academy is because it can bring together leaders, convene leaders from everywhere, from FDA, NIH, academia, pharma, biotechnology, device company, foundations, patients, advocates, communities, all together. And rarely can you do that, mainly because when FDA and a company get together, there are legal constraints of what can and cannot be said and how formal it is. However, we as the neutral convener can bring together these stakeholders to discuss what are the challenges, what are the issues, and how do you actually informally move things forward together. And so the areas of emphasis include what you see in this slide. We have worked on development of target therapeutics, clinical implication of genomic medicine, health IT, use of genomic information for healthcare decision-making, next-generation sequencing, and so on and so forth, including ethical, legal issues. I want to take a minute to tell you who we are. The Institute of Medicine was the health arm of the National Academy of Sciences, which was founded in 1863 by Abraham Lincoln and Congress during the Civil War. At the time, the government of U.S. felt that it needed an independent organization of scholars who can advise the nation non-politically, independently on critical issues of science or art. Of course, over the 152 years, we have evolved to become 3 academies: the National Academy of Science, National Academy of Engineering, and of course the Institute of Medicine, which now in July this year ago, be reconstituted by its charter to become National Academy of Medicine. So we actually, historically, the government depends on us to give them advice. So it's not uncommon that we will hear from Congress, like you hear from Parliament. Congress will commission the NAM or IOM to actually tackle an issue, a study, and then to give recommendations. And those recommendations are therefore usually adopted because Congress already, despite its political issues, have decided to come to IOM or NAM for advice. So we tackle many different issues, including recently the human gene editing issue. Also, so about 50% of our work, although historically 100%, came from the executive branch, the White House, FDA, NIH, CDC, Congress directly, or the VA. The other 50% more recently comes from foundations and others in order for us to expand our question beyond the government needs, more societal needs and global needs, including tackling, as you know, pandemics, preparedness globally, etc. So therefore, we have the ability to convene people and also generate reports. As you can see here, our work on precision medicine over the years have generated many different workshops and reports, which tackles the issue of genome-based diagnostics, the economics of genomic medicine, genome and therapeutics, the evolution of translation omics, and so on and so forth. Now, I want to give you that background because I'll come back and talk about some of the thinking currently about where things should go and how we're using some of our ability to move forward to enable personalized health care. But I think with this background, one would argue that there's tremendous excitement everywhere in many different countries globally, and I've only shown you a few of those who actually have gone forward to say, yes, we believe that precision medicine or personalized medicine is right around the corner. Therefore, we must enhance, facilitate, if not organize, research towards clinical care in this area. And listed out here, of course, is I'll talk a few minutes about the PMI, Precision Medicine Initiative of US, the Genome England, the 100,000 genomes. You'll hear, I gather that Mark Caulfield is going to be here talking about this. Certainly Genome Canada has been in this for a long time, Singapore, Scotland, and I'll say a word about Qatar. So here are two major events by our President of the United States, which announced in January 2015 the Precision Medicine Initiative. In fact, I took this picture sitting on the second row, and the second meeting, which happened a few months ago, when he convened, again, people talk about where the initiative is. And again, this is a picture I took as well. But importantly, I think the issue of the U.S. is the understanding that there is now a time needed to have a more organized approach to this, in addition to the scientific activity in different academias. The idea in short term to look at cancer as a model, but long term to generate knowledge for precision medicine to all areas of health and disease. And so the idea, of course, is to create a national cohort, a cohort for research that begins to move into clinical care. Addition to the cohort, of course, are initiatives to commit to protecting privacy, regulatory modernization, and public-private partnerships. So in February, when this, also the cohort is in fact enrolling 1 million US participants to seek to extend precision medicine to all diseases by building this national cohort. And therefore, it has to design a framework, and there's two ways to identify patients. One is anybody in the United States now can volunteer for this cohort. So actually you, if you're American, can actually say, I want to volunteer my information and enter the precision PMI. The other one is to work with healthcare providers, health systems, health centers to recruit these patients. Okay, so in February 25th, the second meeting, NIH announced an award to Vanderbilt University, and I understand Dan Roden's here, so you can ask him about this, to collaborate with Google Life Sciences to launch the first phase of Precision Medicine Initiative cohort. The NIH announced that it's also, in addition, working with the HHS, which is the Health and Human Services, the Health Services Service Administration, we call HRSA, to partner with federally qualified health centers. These are centers which, in fact, are within the community that serves usually the underrepresented minorities, the under-resourced. Many of them have no insurance or Medicare, but they, in fact, they also want to engage this population to recruit patients. Also, individuals can access and donate their information by a pilot called Sync for Science, which is NIH and ONC. And most importantly, or equally importantly, is the backbone of this 1 million, which is dependent on the vets. The veteran has a 1 million veteran study, which now 450 already are enrolled in this 1 million subjects for PMI. And so their data will be integrated. So you can see that now the movement is really going on with a lot of activities. I think along with this is not only creating a research cohort, but also looking at whether, in fact, the regulatory framework is appropriate to move many of the discoveries forward. So the FDA is really modernizing its next generation sequencing regulation, and also in December 2015 launched Precision FDA, a platform for data sharing to improve the accuracy of next generation sequence testing. As I said, the Department of Health and Human Services, the Office of Civil Rights, also have released new guidelines to clarify patients' rights to access their own health information in format of their choice, and White House released privacy and trusted principles. The VA and Department of Defense is working together to coordinate effort. And finally, the ONC, National Coordinator for Health Technology, is doing data and technology standards. So you can see there's a lot of going on in our country, still very early. But let's take another example of another country, Qatar. The Kingdom of Qatar has about 350,000 Qataris, with a lot, of course, migrant workers. And 2 years ago, a year and a half ago, Her Highness Sheikh Kamoza, the chair of Qatar Foundation, declared that, in fact, Qatar will sequence every one of its subjects, citizens, to create a roadmap to integrate with the delivery of care, to integrate electronic health record as a way towards personalized medicine. I'm very fortunate to chair the scientific advisory committee of this Carta Genome, which in fact looks at moving towards integration of information to care, but also develop it as a scientific leader. And importantly, it's building 6 different building blocks, from a biobank, which is already in existence for several years, to a genome information system, a sequencing center, developing workforce capacity, ethics policy, and of course a research agenda. I mainly point out to you about the excitement of so many countries, including yours, and now begin to organize beyond the academic research alone, but towards a more systematic way of how to move eventually not only research, but towards patient care. So now what I'd like to do is talk about how does that happen? What are the challenges? Well, first of all, I have these 5 different areas I want to discuss. First is the generation of evidence. You know, before precision medicine can be integrated in clinical and preventive practice, there's a need to develop, of course, a robust evidentiary foundation for its use. And so, question is, what is the bar which set for evidence generation? How do we generate that evidence? Secondly, in order for the technology, whether it's diagnostic or treatment, to be utilized, it needs to go through regulatory and reimbursement environment. What are we today, and what are the challenges and where we need to be? Third, of course, is to integrate into practice. How do you do that? Data infrastructure, and of course, importantly, public and patient engagement, the ownership, the privacy, the trust, and those issues, which I'll talk about these 5 areas. So first, of course, is the evidence that at the end of the day, if we're going to have this whole area moving forward, we have to believe that the utilization of precision medicine or personalized medicine improves clinical outcome, improves the quality of care, at least the experience of the patient, not having to go from test to test to test, but also make it cost effective. Because the big concern of so many people is precision medicine is just going to drive up the cost and increase the health disparities. So I think it's really important that we generate evidence that actually meets those goals in the long run. But generate evidence is not easy, because as you can imagine, the standards of generating evidence to date are a big challenge. What's enough? What's appropriate evidence? By the, shall we say, the standard, it's randomized controlled trials. Is that appropriate? You know, particularly when you think about it's getting more and more difficult to do randomized controlled trial, particularly in diagnostics. And I'll come back to that in a little while. And of course, finally, we do want to know that if you approve a precision medicine technology, a medicine or diagnostic, that is actually going to be used, and they're used appropriately. So these are the evidence generation questions. Now, so I think it's difficult to generate conclusive evidence sometimes if you don't do, quote, a randomized controlled trial. And getting trials approved is not easy, particularly if you ask people who are in the diagnostic arena, because the speed at which biomedical advances are being made, the diversity of patient population, drugs and diagnostics, and of course looking at a smaller population for targeted therapies, generating what we call traditional evidence for regulatory and reimbursement decision is getting very difficult. I think if you talk to many people, you know, they say it's impossible for us to actually have a test going forward because we don't have enough funding. There's the bar set way too high. So I think that one has to recognize that sometimes evidence is generated after you have introduced into practice, because that information will help you actually generate the robust information data that you actually need. So the question is, how do you actually create a flexible framework to balance between the use of RCTs, big data, observational analysis in precision medicine to be developed and adopted? So I think this is, of course, one idea would be that you need different thresholds for initial clinical utility. That in fact you could have a certain standard for approval, after which is provisional. Then you need to generate the data in usage over time to demonstrate that you actually met those expectations in the post-marketing arena. I'll talk about that. The other really important issue is the economic impact, because precision medicine promises at least a cost-effective approach, right? That's what we say. Listen, if you've got a targeted therapy, you don't have to do trial and error, you're more likely to get a result quicker. You have a targeted diagnostic, you don't have to do multiple tests, you actually can shorten the test. So that has implication that it's going to be cost-effective, if not at least reduce costs. Is there any evidence? Are we going to keep approving technology without that evidence? So I think an economic impact of this approach, to me, is necessary as part of consideration for regulatory framework and reimbursement. How do you do that? So I think the question which I like to propose is to say one can have an approach of provisional approval with a final approval contingent on inclusion of, in fact, the evidence based on economic impact and outcomes. And of course, needless to say, today we are not faced with that situation because it's inconsistent standards for regulatory approval, reimbursement limit integration into practice, and of course, a reimbursement does not reward value. In fact, diagnostics are reimbursed on a cost base, not a value base. Okay, so that's what I want to talk about. So this paper published in 2013, really, I think in many ways, by Hayes, emphasized the problem with this. Because if you imagine that wherever you want to start looking at, utility is poorly valued. In other words, if I had a diagnostic test and, most people would undervalue how much it would be used, and therefore there's inadequate funding investment for such a type research. Consequently, there's much less ability to conduct proper studies, and therefore the reduced data certainty, and therefore results in a vicious cycle. So our suggestion would be, and in fact I wrote a paper on this very important issue, which I'd like to just take a minute to point out to you. With Jeff Ginsburg and Dana Goldman at USC, who's a health economist, we actually took a look at what if you take 5 major diagnoses. In this case, cancer, diabetes, heart disease, hypertension, lung disease, and stroke. And what if you look at a diagnostic which is able to predict these different diseases? And what if you look at a 10-year, or actually more than a 20-year time frame, if you reduce the onset of this disease by 10% or 50%, you can see the savings is tremendous. And if, particularly in heart disease and diabetes, the saving is hundreds of billions of dollars. But if you had a test to say, I can predict who's going to get cardiovascular disease, but you won't see the savings until 10 to 20 years from now, nobody's going to reimburse you for that test, right? So our argument is that you have to be able to at least take that into account if you really want to realize precision health and preventive health. And so in that regard, the thinking that I have with Jeff Ginsburg right now is to say, what do we first, these are the gateways, that if you had a test or drug, drug's a little bit easier, but I would argue quickly that innovative medicine is driving up the cost of care enormously. And if you take cancer treatment, maybe it's extending life by 3 months. But if you look at hepatitis C, one would argue that in fact you have much downstream savings, right? And yet many people are really worried that it's going to bankrupt the government immediately. So how do you balance between short-term and long-term gains? One would argue that first, you show proof of concept of clinical effectiveness, but that at least you have, if possible, within your design study, health economics. If not, I would argue that using what I just showed you, economic modeling, a modeling in which the regulatory agency and the reimbursement agency can accept to say, yes, you do show that if we support this, we can save money 10 years from now in a big way. And then long-term impact. And if those things are in place, why not approve it? And then do a post-marketing validation. That is, using big data now we can generate, following the population. And then you can say, well, yes, it didn't meet the expectation in the time frame they set, and therefore we continue to approve it, or no, it didn't, and therefore it ceased to be approved or reimbursed. So this is a schematic diagram, what I'm thinking about. If you look at the top, let's see if I know, oops. Well, if you look at the, okay, investigative and experimental. This is during the research phase of a diagnostic or drug, in which, of course, you look at the validity both analytically and clinically. That is, you have proof of concept, is clinically effective. This can be done on a relatively small population, but you also include an economic impact analysis, whether it's done as a prospective study in health economics or as a modeling, because it takes too long to realize the benefit. In that case, one can improve this drug with, or test with provision. And then you can see on the top line, ongoing data collection. That is using, this is one of our reports, using ongoing collection of data so that you have more evidence, adequate evidence for clinical utility, including cost effectiveness. In this case, at the end of the period, it's a go to no-go decision to continue or not. And of course, as you see in the very bottom line, the strength of evidence will get stronger and stronger as you collect big data on the population who, in fact, have been utilizing the test or the therapeutics. Now, one could even argue even more strongly in countries that's really worried about cost, to put that as a gate, which, of course, I'm not proposing here. I know that in U.S. it could be, people say that's too aggressive, but you can see that you can go through initial yes, no, and then at least an economic impact, yes, no, like NICE does in drug approval, then to go to provisional approval to eventually getting the data. So that's evidence generation, more and more moving away from the classical RCT, and maybe in the small RCT study, more and more looking at observational and big data. Approval processes more moving into what's thinking about economic impact as well, and provisional approval towards getting the evidence generating as you go, learning how to use the new technology and looking at outcomes as well as cost effectiveness. Let's talk about the challenges of integration in clinical care. We have equally amount of challenges because of the perhaps the need for education of clinicians and patients, the need to integrate into care pathways versus used somewhat randomly, the need for clinical decision support, and ensuring, of course, an educated workforce, and, of course, ultimately, electronic health record, right now not able to handle genetic information. So at the IOM, NAM, we have looked at a number of this situation, implementation of science approach to genomic medicine, and look at potential solutions towards how do you integrate into clinical practice. First of all, it's really important that, of course, precision medicine tools, diagnostic or therapeutics, being able to look at as a part and parcel of the care pathway, and therefore developing clinical guidelines, particularly diagnostic integrated care pathways. This is critically important because, after all, how to use them. And if it's integrated pathways, then you can measure, and therefore you can measure, actually add clinical decision support on top of this. I think a much greater investment needs to be made in translational health research, particularly in implementation science, outcomes and public impact. Of course, you need clinician education, and ultimately you need for performance metrics and incentives. You know, so much of our care these days, we're measuring how people are doing. If, in fact, one of the clear precision medicine diagnostic, for example, should be used, we can look at how our providers are using them and either incentivize them or at least report how people are performing. I think all those things are very important in the integration into practice. Now, so we talked about education and, of course, interprofessional education, but patient education, not only in terms of genetic counselors, but in fact, everyday usage, understanding of how to use more and more these diagnostic tests and therapeutics. Now, one area we've been working on is to say, because right now there's really no integration across the country and how the genetic information is integrated into electronic health record, the roundtable begin to think about initiative, and has started an initiative called Displaying and Integrating Genetic Information through Electronic Health Record. And here, this initiative is really what we call action collaborative. That is, people are voluntarily collaborating to do this. And I'll show you the 8 centers which are working together. And really thinking about how to address some of the challenges related to integrating genetic data in electronic health record. And of course, the purpose of this is to engage various stakeholders in health and healthcare informatics to develop a scalable framework for genomic data integration, related decision support tools right into existing electronic health record platforms, since people all have different electronic health platforms. And so one of the importance is to identify standards across different organizations to agree the standards to enable transfer of lab interpreted results into electronic health record, and of course to implement this well. So 8 institutions are now participating, including Partners Healthcare at Harvard, Duke, St. Jude, Mission Health, Boston Children's, Johns Hopkins, etc. And what these 8 institutions are doing is to agree that in order to have laboratory interpreted results integrate electronic health record, it has to at least contain the following. If you look at drugs, the metabolic information, the genes, which in fact are in the nomenclature of the Human Genome Variation Society, the metabolic status of any variants of the gene to metabolize drugs, and of course, sensitivity to drugs, which are the genes, the drugs, and sensitivity status. So to initiate this across all different institutions, we're looking at 2 variants, HLA57 and TMPM, which looks at, in fact, first a abivir, which is a drug, has hypersensitivity, and on the TMPM, azathioprine dosing. I'm showing you this because you'll be amazed when you think about how to initiate this, how different, I would say, in Montreal, from the McGill to the University of Montreal systems and different systems, that only they're not talking to each other, there's not even any standard integrating in electronic health record using precision medicine. So this, in fact, is one area of example. The other important area, of course, is the data. Data is, in fact, the heart of precision medicine, and I'm sure you heard from David Auschler and others, the problem with lack of data standards, lack of interoperability, and lack of data sharing platforms. And there should be, in fact, the need for this. Now, Peter Goodhand is speaking at this meeting, and as you know, he leads an organization called GA4GH, which in fact is an international coalition that brings together scientists, university, pharma, etc., to begin to establish a common framework of harmonized approaches to effective and response sharing of genomic and clinical data. I'm sure he's going to tell you a lot more about this. Finally, patient engagement. Patients, of course, I mean, at the end of the day, it's all about the patients. So they have tangible concerns at this point about privacy, about inappropriate use of the information. So they have concerns about who owns this data and who authorized the use of genetic information. And of course, this big concern about aggravating health disparities economically or otherwise. So I think that in this regard, in terms of data ownership privacy, there needs to be an ethical, standardized approach to data collection and sharing, a need for consistent policy of data ownership, security of personal data, and of course the fear of dissemination based on personal information. So we have, as others, been working on this particular issue, and some of the solutions are in fact in the slide, which includes legislation, as you heard from Pavel Hammett, about protection against discrimination, genetic information. We have a thing called GINA United States. We have improved consent models, patient participation engagement plans, education, particular programs targeting underserved population, and research agenda, very importantly, to understand values, beliefs, knowledge of different patient groups, different cultures, to precision medicine as the key barriers to effective patient engagement. So as I look towards what's in the future, I'll say that what we need are robust evidence based that precision medicine is going to be value added, not just another technology, not just another new drug, but in fact, whatever we go forward, it has to improve outcomes and at least be cost effective. It could increase costs some, but if the outcomes are better, that's great. But certainly we not want to see runaway costs without the effectiveness. It would be great if you can actually low cost, as I showed in certain diagnostics, that you can target population for prevention and early intervention. We also need a flexible framework to balance the use of RCTs, big data, observational analysis, and of course we need regulatory and payment modernization. We need technology information technology to support PM, establish data sharing, governance, and ownership frameworks, adequate trained workforce, and integrate it into routine practice. We need public education, outreach, and understand, of course, patient preferences, beliefs, literacy, and values. We need public-private partnership, working together, industry, academia, government, and patients. And we need a national learning health system, a system that actually scaled nationally so that there's learning, as I talk about, in sharing approaches, electronic health record, and economy of scale also by thinking about a global collaboration, which is why the purpose of this meeting, the international meeting. So we have indeed thought about this at the IOM and NAM in generating a few reports on this area, but here is a national scale learning system where everybody participates in the generation of information, learning from our success and mistakes, and moving quality care improvement. In this regard, you need a system integrated capacity, particularly in data. Data, electronic health record, being able to manage not only individual segments, but across, in fact, the nation, if not globally, so that the users can ultimately improve patient health care. So the idea would be to move forward, as I said, we need a supportive policy environment, a data infrastructure, and process to improve patient care. Now, so there is, in fact, since meeting is international, there's now a good amount of activities moving this direction. This paper, written by so many of us, actually is initiated by National Academy in a meeting that talked about global collaboration. And from this on, in fact, there is a collaborative called Genomic Medicine Collaborative, or G2MC, launched in 2014 as an actual collaborative off the round table to bring together people from all different countries to learn, to discuss, as this meeting is all about, international meeting, and to define goals to work together. And of course, at the World Economic Forum and a Council, Global Agenda Council, I chaired the position in personalized medicine, also to bring private sector into the equation, to move towards partnership as a global solution. So I'd like to conclude by saying, what is the promise of precision medicine or personalized healthcare? The question we have to say is, will it address the issue of quality, cost, and access to care? It must. Otherwise, it's not value added. Would it increase cost? Will it, in fact, make health disparities worse because those who can afford it versus who can't? And in fact, it aggravates certain socioeconomic issues. And would it improve the health of the public? I would say that if done properly, as we discussed, with a long way to go, which I'm sure is the purpose of today's meeting, is the idea of how to fully integrate all that data that you have into electronic health record and implement it into healthcare delivery. It's a tall order, but the journey has begun. And ultimately, we want to improve outcomes and have cost effectiveness. But I want to say a word about public health, because I think that precision medicine or health has great implication in public health. Whereas there's this argument whether precision medicine is the other side of public health is bogus, because genomic biomarkers can identify the patient risk. Remember I told you about risk factors? So imagine you apply this to your population. You can look at, as I showed you our Lancet paper, early intervention, delay the onset, if not preventive altogether. Now, in the context of pandemics, infectious outbreak, I think genomic technology has tremendous usage in point-of-care diagnosis of you knowing what in fact is outbreak, being able to track whether it's the same pathogen in different outbreaks, and being able to target, in fact, early surveillance, tracking, monitoring, and public health measures. So I think this technology is fully integrated in the health of the population as a whole, and it's got to be used properly. So as an example, one of our work is to look at how to look at population health and genomics together. And one of the working groups is looking at BRCA 1 and 2 as an example to look at a horizontal scan to examine what evidence needed to decide if the test should be applied at the population level. Should everybody get it? Is it cost effective to go from a tier 1 CDC to a subset of broader population? So the implementation of this working group will be to look at what's the level of state readiness for implementing genomic programs, and in fact, what is the outcome metrics needed. In case you think this is dreaming, Michigan State actually started 2002, a long time ago, when they took genetics program right into cancer in the Michigan Department of Health and Human Services. That in fact they have in public health full-time genomics coordinator and genetics staffer to look at this. And of course, as you can see, they use BRCA as an example, using it as counseling and testing, and ended up health plans are now covering for this, 16 out of 25 health plans. They awarded 8 out of 25 health plans with a written policy for clinical service for women with known deleterious mutation aligned, reduce barriers for BRCA testing, and receive the Spirit of Collaboration Award. That's only a small slice, but imagine begin to use this more extensively in cancer public health, if not cardiovascular public health and others. So my last slide. I think to realize the promised precision medicine, it must address the issue of quality, cost, and access to care. These are three things that every country is tackling, right? How do all the subjects have access to health care? In our country now, we're proud to say the Affordable Care Act now has taken the uninsured down to less than 10%. That's a great progress going forward. Quality. Where's the evidence that by introducing precision medicine, we've improved the quality of care in terms of outcomes, but quality of patient experience without having to do excessive diagnostic testing, etc. And of course, cost effectiveness at least, if not reducing cost. I think it must improve clinical outcomes. It must be cost effective. It must not increase health inequity so that people can have access to it because it's cost affordable, and it should improve population and public health. So thank you very much for asking me to kick off this meeting by bringing up the issue. You can see the journey is very exciting. It's in a way beginning, well maybe in the 1/3 phase. I think that this conference should be a great forum for discussion on the issues I've identified and many issues that you've identified, and hopefully we'll all move forward together. Thank you very much. Do you want me to answer questions?
So thank you, Dr. Dzau, for this beautiful and very inspiring talk. We have time for a couple of questions from the room. Pavel?
Thank you very much for proving that I was right, that we uninvited you. The one question I have, though, by listening carefully what all you have said, I have a feeling that we are not doing a good job from, the public health is saying this, everything is environment, but they always mention genetics. And we do a little bit the reverse. We always mention environment, and we really mean genetics. And I think that the tools of seeing how they impact each other, how to quantify impact of environment in the presence of genomic makeup, how the environment is impacting the transcription and final outcome. I think that the tools are still missing how to quantify that and how to translate that to practice.
Thank you, Pavel. I think you're right on. I didn't talk about the research possibility, but certainly by bringing in the current quantitative data and the use of the various technology, one can certainly begin to look at the impact of environment on genetic susceptibility or vulnerability. And that's part of the research agenda that can influence public health. Thank you.
Thank you.
Rainer Banken, I'm a consultant in health technology assessment. I would like to have your thoughts about the cost of pharmaceuticals. I think the promise of precision medicine is treating smaller populations, which is a challenge for science. I think on the science side, we can move ahead with big data, with adaptive trial designs, with randomized registry trials and things like that. On the cost side, if the cost of pharmaceuticals are going to increase astronomically as they have been over the last years, the cost effectiveness really will be a big problem. So how do you see in the current environment of the US healthcare market this issue of drug pricing as related to precision medicine?
Right. I think your point's well taken. I hope that what I was saying in my talk was we now need to take health economics into equation. I was in Davos World Economic Forum, 8 health ministers talk about innovative drugs. They all worry about runaway cost. Every country, not just US. So I think the equation should be an assessment about the economics of this. I think if you assess the economics, there may be some impact on how to price the drugs. In other words, you can look at what in fact is the effectiveness, the cost effectiveness, because to calculate cost effectiveness, you have to calculate into the cost of the drugs themselves, right? So I think that's one idea of going forward. Do you have any other ideas?
I mean, that will be a revolution, especially in the United States,
I
think.
know. Well, we're trying to push for it. I'm writing 2 papers on this.
Ed Abraham's Personalized Medicine Coalition. My question actually follows on.
Come a little closer to the microphone, Ed.
Thank you. Thank you. My question actually follows on the one previously. You very wisely mentioned we need evidence to demonstrate the cost effectiveness of personalized medicine, or we're going to run into this tsunami that we can't afford it and therefore shouldn't have it. So my question is, who's responsible and how are we going to collect that evidence, which isn't going to be inexpensive?
First of all, I think the market's asking for it. So like it or not, this is going to be a drumbeat because, you have the payers who's going to have to think about, what am I going to pay for all this stuff, right? And you have the government, Medicare, who have to think about all this. So to some extent, I think that demands for that evidence is going to higher and higher. If I were a pharma industry, I would incorporate the health economics data from day one study into the trials, which probably would not be much more expensive. But as I said, there's another way to do this. If it's not possible, at least in my mind, if you use good modeling to show the data, and if the modeling is validated through some framework or the others, it's at least good enough for consideration. But we have to have that, in my mind, as part of the consideration.
Thank you.
Thanks, Ed.
You've spoken about the access of genomic information that is already being made available to patients, and you have mentioned that on your list of priorities is patient education, but I wonder what kind of strategies are in place, because as we know, a little bit of information can be a dangerous thing, and providing genomic information without the appropriate education to the patient could create issues. So I'd like you to address what's being done.
Sure. Thank you. I think that we have a long way to go. I think your points were taken. Right now, I would say is the willing. In other words, those people who are interested, and of course, patient advocacy group with genetic disease are very strong, and they're very interested, very knowledgeable, all the way to people who are volunteering. For example, with PMI, I think one of the very impressive focus actually is patient engagement. That's really big in PMI, the 1 million people, so people can actually participate, learn, etc. I don't think it's quite ready yet to disseminate that information, nor are we at that stage. But countries like Qatar and Singapore actually have a chance to do this on scale because they're much smaller in terms of engaging patients and looking at, step by step in terms of understanding what, as I said, what are beliefs, values, etc. But your points are taken. I don't think we're there yet.
Ségolène Aimé, INSERM, Paris, France.
Yes.
You rightly stated that the generation of evidence is quite a challenge, especially when we need to deliver enough evidence for the regulatory framework which is in place. But you didn't say that there is currently an example to follow, which is the field of orphan drugs, because we are very used in that field to have early market access and the obligation to generate evidence post-marketing. So why didn't you mention that? Because there is like 30 years of experience in that field?
No, thank you for mentioning it. I'm sorry I didn't. Thank you.
Philippe Frogel, Imperial College London. In Europe, some colleagues, including in Academy of Science, for instance in France, consider unethical the sequencing of the human genome for common traits, and especially in people who are not sick. And in France, for instance, it's illegal to ask someone to sequence your own genome. And if you are not a geneticist, you cannot prescribe NGS. Do you have this kind of discussion in the US, and do you discuss with your peers in other academy of science or medicine elsewhere? Because I really believe that we need some kind of discussion worldwide to have a consensus on this important thing for precision medicine.
So if you can clarify for me, if an individual wants to have a genome sequence, is that permissible?
The only way to do it is to do a gift for research. But if your father died or from a cancer, your grandfather or something, and you want to know if you have a mutation, that you cannot do it. So some people send their saliva to 23andMe or other companies, but if I want to do it in France, I create a company, I can be in jail.
I see. We don't have such regulation in the United States, and my colleagues can correct me if I'm wrong. So it's, if an individual wants to have a sequence, as you already mentioned, there's plenty of opportunities in commercial sources, etc. And that information belongs to the patient themselves. So I think right now sequencing in the United States, hospitals, etc., is done either under research or very clearly under care of the patient, not just out of curiosity. There's no organized sequencing for the normal population like this, although now, as you can see, we're moving into that direction with research.
Okay, thank you.
Hi, you've talked about your standardization of data entry for your big data project. How were the physicians receptive to all this process itself?
Good question. Well, I think you're asking questions a little bit more than just simply genomics or precision medicine, just simply the issue of electronic health record and large amount of data analytics. I think it's a mixed response. Most people are aware that this is the direction that healthcare has to go. The amount of information will be enormously helpful. And I think for the practitioners, there are so many changes going on in their life. This, of course, additional burden in some of the work. So I think we have a mixed response. But this is really mainly talking about practitioners who are trying to use electronic health record and clinical decision systems, right? The big data, of course, is collected not through their work, analyzed, but in fact through more research and data centers. But I say the frontline clinicians are finding excessive workload and less time for patient interaction. At least that's what we hear in the United States. And some are not so happy. I think most people would agree that if implemented correctly in the long run, this is the right direction to go. Thank you.
Thank you very much for the excellent presentation. I have a question about the provisional approach you were suggesting around reimbursement. So we've actually been talking to our payers in Ontario about that approach for some time. And the pushback that we get is, what happens if we come to a place where we have to remove those products from the formulary, and how do we handle that with our patients? Have you thought about that at all?
Yeah, that's a really tough issue. I mean, it's the usual, once you say yes, can you actually turn off the tap, right? I think that would be hard, but that would mean that you really have to believe that you have to be able to do that. Otherwise, there's no point for provisional, right? So I've just simply presented as an example of where things can go, how we're going to, end up making this a pathway of policy. Still a lot of work to do.
So any other questions for Dr. Dzau? If I may ask the last question.
Of course.
Yes. Are you aware of some initiatives that are focusing on inequity? Because you mentioned that it's a problem that may occur.
Actually, we are looking at that issue very carefully. I'm not sure whether it's going to be that easy to find that data, but certainly it needs to be looked at very carefully about what does it mean if we introduce these tests which may be more expensive. And that's why I do believe that cost effectiveness is a very important part of the analysis. Because if you do that, then you probably reduce the probability of inequity in that regard.
Thank you.
Are you aware of any?
No. We will have a discussion on a panel discussion on that today, just following your talk. In fact, after the break, but
That's great.
yes, we are starting. So thank you so
Thank
much
you.
for your great
Thank
talk.
You.